Hey guys, this is my clinical CAT scan following up on the vignette I'm tentatively calling Nick's toothache. So again, it was tooth number 31. This was the CAT scan taken the day after I started noticing some discomfort in the tooth. We went over this in one of our treatment planning sessions, but I wanted to go over it again because I have more information at this point. But let's just review what I noticed on day 2. Just severe toothache, more of a severe dull ache than a severe jabbing pain like you would notice with a tooth that is undergoing irreversible pulpitis. Although, in retrospect, it was really hard to tell. All I could say is it was severe. It wasn't just a nuisance. So here we have the lingual concavity, and we had talked about the fact that this periodontal pocket was present. I do brush my teeth and floss regularly. With that said, this torus that you're seeing here, I have very pronounced tori, is unfortunately invading biologic width. So I think long term I have a chronic perio pocket here that hasn't broken down to the point where it's been inflamed and been picked up during cleanings, but at some point this is likely to be contributory. So that's one area of potential contribution to my symptoms. Obviously, the shoulder operation I had 10 days before, I think, may or may not have had something to do with this. My original assumption was the following. All right, so we're looking at this image here. You can see, let me just start on the mesial root so you get a full sense of the tooth from this axial slice. So there's the mesial root system. Really nothing significant there, no decay in the tooth. I don't have any parafunction, so I wouldn't think there's any cracks. Then here's our distal root. And as we noted during our treatment planning session, I made the point that sometimes teeth in this area actually exist a little bit outside of the cortical bone. This is why, I'm going to take a small little tangent, but I think it's important. This is why it's important when we extract teeth. If we put too much buccal force or force in a buccal direction, there's going to be a reciprocating lingual force. One of the reasons why patients sometimes end up with bony sequestra in this area has to do with the fact that when we rotate the tooth out, we potentially fracture the lingual plate here, and then a bony spur gives way, and this thin mucosal tissue that's overlying this area eventually gets irritated by that bony island, and I have seen several of these over my career from teeth I've extracted and others have extracted. So I'd say it's a normal sequelae of dental extractions. With that said, I think it's a good reason that we use our sectioning techniques to remove teeth without a buccal lingual force of extraction. With that said, that's a topic for another day. The point is that sometimes the teeth live outside the alveolar housing, and this bone in this area, if injured, can exfoliate and irritate the tissue, and the patients can have pain at a point somewhat far away from the initial treatment. I'm talking weeks and months after an extraction, or in my case, a supposed injury from intubation. So my thought was at this point in time that they had intubated me and they had, irritated the mucosal lining, and because the tooth had almost like a communication through the cortical bone, that the inflammation associated with the mucosal lining caused my tooth to rise up, which was true because Dr. Libby adjusted the tooth on this Sunday, which is day 2, and it felt much better. So at that point, I went home thinking that's all it was. My hope was that the pulp inside the tooth wasn't affected to the point that I needed a root canal. He had definitely adjusted it to the point where I felt like it was no longer touching. So that's the end of my experience on day 2. I'm going to continue my PowerPoint presentation, and I will come back with another video with another CAT scan.